Everybody can see it, hopefully?
Yes.
Great. So I'm going to start out, and my section is going to be sort of providing an overview of a family systems model that can be applied to all types of chronic illness and disability in a variety of healthcare settings. And then Maureen Davey and Lauren DeCaprel are going to give clinical examples, specifically working with cancer couples coping with survivorship, and then Lauren's work with end-of-life issues. So my work is really, my section is to provide you with a way of thinking systemically. Many of you might work in very different settings, and it's with the understanding that this is a way of thinking that can be applied at different levels, everything from brief interactions with families in the context of inpatient care, all the way to providing a brief consultation or assessment, to doing in-depth family therapy. Doherty and Baird's work of these different levels of involvement is important because this model and way of thinking should be something you can just draw on. My work has been specifically across a range of programs from primary care to cancer care to hospice care in a variety of settings. So the starting point is families' experience, and I'm not going to be talking so much about collaboration here. I'm going to be specifically talking about a model that you can use when you are talking to families. And families here is in its broadest sense who families consider family. In some situations, it's an emergent family. When I worked with HIV, it was people who gravitated or became the caregiving group for a particular individual. The key is that it is viewed as an uninvited family guest. So this is a way of, so that it's not inside the person, but actually families can begin to think of the illness as something that they all have to relate to. The keys are going to be keeping the illness in its place and strengthening the family. So the work that I do is very much focused on a strength-based model rather than a deficit-based model. Okay. So within that, you begin to think of the family as a key resource and partner in care. A lot of the early work in my work, in psychiatry, much more views, there's been a historical view of families being problematic in the context of chronic disease or specifically major mental health issues. So here we're looking at it as a resource, and that illness is going to affect all aspects of family life, all members in all relationships, and that there's a mutual influence between illness and family, meaning it's not just the impact on the family, but also how family processes can affect the disease, specifically, most importantly, adherence to treatment. And that there's a lot of data on how family organization processes can influence that, as well as, in certain cases, disease course. Okay. So the family systems model that I've developed is collaborative. It's, as I've said, resilience-based. I'm going to be talking a little bit about it. It's a developmental model because when you're working with chronic disease, you really have to have a way of thinking across time. It's not a cross-sectional model is less useful. And how do you think about different types of development? So most healthcare providers are focused on the illness's development. In this case, I think about how the illness develops in relation to family development as well as each person's individual development. Okay. Most families don't have a map for this experience. So the types of things I'm interested in with families is their belief system, how are they organized, and how do they communicate. I also want them to develop a psychosocial understanding of the illness, which I'll talk about in a minute. And this has to do with transferring all that biological information into something that's psychosocially meaningful, as well as understanding sort of something about development. Okay. So this is the way I diagram that. I think of illnesses. I think about really the pattern of diseases, so less about diabetes, cancer, multiple sclerosis. I think about what is the pattern of a disease over time and what is that going to means psychosocially. The other thing that I think about is much more about the fit between a family and an illness. So if you look at the far left here, all families have a practical and emotional style. And we can also talk about all diseases having practical and emotional demands. So the question is really the fit between those, rather than there's bad diseases and good diseases or healthy families or dysfunctional families. You're really looking much more at that fit and how that fit may change over time depending on the phase of the illness as well as changes in individual and family development. So just to give you an idea, these are the aspects of illness, and you can take any disease and think about it. You know, is it acute onset versus gradual? That would be like a stroke or Alzheimer's disease. Is it progressive, like Alzheimer's disease, constant, which would be like a spinal cord injury, or relapsing, like asthma? Is the outcome going to affect lifespan, meaning it is clearly fatal, or as many diseases they can shorten lifespan, or they do not affect lifespan? And then the level of disability. What I'm interested in when I meet a family is what have they been told, and then what do they believe? So a very simple clinical example of that was a case that came in. This was a man who had a skin cancer that was the not serious form of skin cancer. It was a basal cell, and you have to be careful. But it's not, the physician told him it's not something that is fatal. When they went home, the husband believed that, but his wife believed that he had a fatal illness, and they got into a lot of conflict in a very short period of time that led to a consultation with me. When I met with them, I asked them what were they told. They both said, we were told it's not life-threatening. I said, what do you believe? The husband said, not life-threatening. The wife said, I believe he has a fatal illness. And I asked her why the discrepancy, and she gave one sentence: because my own father had a misdiagnosed, meaning the doctors make a mistake, malignant melanoma, which is a very serious form of skin cancer. In her particular case, the fact that it had been misdiagnosed became clear at 4 or 5 months, and then her father died at about 10 months. The way I used that was because she was going to be so fearful for those first 4 or 5 months. And by the way, as soon as the husband heard that story, he became very empathic to his wife. He did not know. He knew that his wife's father had died of cancer, but did not know it was malignant melanoma and did not know about the misdiagnosis. What I did collaboratively was to call the dermatologist and reveal this information. I said, this woman's going to suffer a great deal. Rather than wait a year for the regular checkup, could you just check this man at 4 months, just take 5 minutes, because she will be so anxious during that time. So that's where I was using the information coming from the spouse to ask the provider to provide an extra few minutes of care in order to allay any anxiety, which in this case, there was nothing seriously wrong. Okay. The other thing I do is I think about time phases of illness, and broadly speaking, I think about that initial crisis phase, I think about a chronic phase, and if a disease is terminal, I think about a terminal phase. And the transitions between these phases are as important as the phases themselves. There's some writing you can go to that will go into this in more detail, but there's several ones that I think are particularly the most important to keep in mind. One, that the family define the challenge of the illness in shared we terms. That means that there can be caregiving burden, there can be physical burden, but you don't get focused on, this is my illness. If families take a we position, a lot of the difficulties I see down the road where there's imbalances that develop in the family can be avoided to a great deal. This is particularly true for couples in my experience. The other part is establishing a functional collaborative relationship with the healthcare team. And again, in these situations, obviously there might be the primary care provider and it might be also specialty care providers. So it's really making sure that there's connections between all those folks. Okay. One of the other early issues is communication. Who will be included and excluded and why? what topics are going to be off limits and why. Basically, there's no evidence that children and adolescents are hurt by age-appropriate information. If a child asks a question, for instance, could I die from this, or could mom die from this, I feel the best answer, if that's true, is to say, yes, that's possible, but the doctors are very optimistic or hopeful. But rather than say, no, that's not possible, because kids do learn through a variety of ways when they do have life-threatening conditions or another family member does. And there's a lot of evidence that when those communications get blocked, there's anxiety, depression, school-related issues. So this is very important to me, is to ask these questions and find out. Often family members are afraid to bring up topics, but they would like to talk with them, but believe other family members wouldn't want to. I've done that as an exercise, and usually people find they're off limit. What they think is off limits, the other family members want to talk about just as well. Okay. So the work I do, I use family consultations preventively. I use them at crucial transitions. Sometimes families dealing with long-term illnesses like to have psychosocial checkups, meaning just like a physical. Every 6 months to a year, we just meet for a psychosocial consultation. Okay. On the level of dimension of time, I'm interested in what do people bring from their past to this illness, where does it land in their lives, and how do we think into the future in terms of how this disease is going to keep intersecting with individual and family development. Okay. So in terms of the past, these are some of the questions I will ask. How did the family organize itself as a system in response to prior illnesses? What did family members learn from those experiences? And what are the learned differences among key family members? So this is particularly relevant for parents. Sometimes they have had very different experiences, and based on that, they will want to take a very different approach to a chronic disease that emerges in their family. Okay. So this is just one quick example of how that can occur. Hopefully you're all a little bit familiar with genograms. This is a case where a child is diagnosed with diabetes, and a 6-year-old, no prior mental health history in the family. And what happens is the kid is doing very well, but the mom is calling the pediatrician every other day, very, very worried about her son and that something is terribly wrong. The pediatrician asks me to do a consultation because she says, I've known this family for 6 years and I don't know exactly what's going on. When I met with them, you can see that the husband had sort of pulled back and distanced, and the mother and her son were getting very, very closely bonded. When I asked the father about any experience he had with chronic disease, he said, yes, when I was 5, my father had a heart attack. My mother became the caregiver, and I said, what was your role? He says, I just kind of pulled back and raised myself because I thought the caregiving going on between mom and dad worked, and I didn't want to get in the way. So what he does here, he kind of says, I've seen this before. My wife is taking care of her son. I'll just pull back. In her story, it's a little different. She's the oldest. Her father was a chronic alcoholic who would come home drunk and be verbally abusive to the mother. And her role was to really kind of comfort her mother, which she felt like she had failed at. She would also sort of push her father into a room to sleep off his drunkenness. So in this case situation, she carries some sense of shame that she didn't do a good job because everything's still the same in her family of origin. So she overemphasizes the risk to her son because to get another chance at rescuing it and doing it right this time. And the only thing that was unconscious was she sort of pushed her husband away, which is what she had to do with her dad before she comforted her mom. Now, in this case, just asking these questions because it was early on, because the pediatrician made an early referral, the couple said essentially, oh my God, I see what we're doing. And they stopped. I didn't do any of family origin work. There was one additional follow-up, and essentially this family had rebalanced itself. You can see if there was no intervention here, this is the kind of case when this kid reached early adolescence that could easily be the emergency room case with all kinds of problems in the parental relationship and over-involvement, enmeshment between the mother and son. Okay. As I said, life cycle thinking is a way you can then organize yourselves to thinking. I again think about what phases of family development are coming up. Is an individual going through development? And those are natural points where the illness may be just fine, but the family gets into upheaval. And let me give you a couple of examples, quick examples. Very typically couples, I've worked a lot with couples that are dealing with diabetes. Usually one person, if it's type 1, has had that for a number of years already. But the well spouse has to learn how to live with diabetes. And you'll often see when they make a decision to have a child that there's a period of upheaval. And what's going on at that point, let's say it's the wife who has diabetes, is you're taking a day-to-day relationship with a chronic disease, and now you're doing a 20-year plan. So what comes up in that is 20 years is a very different length of time for a couple dealing with a chronic disease. There could be complications that become a concern. There can be extra risks during a pregnancy for a woman. There could be concerns about genetics. There could be concerns about disability and what would that mean for the other spouse in terms of taking care of things. Those are the kinds of issues that could come up with a chronic disease like diabetes that's being well managed, but they're going into a major new stage of development. This is a time where I think a consultation, a prevention-oriented consultation, can be extremely useful. Again, it's not based on the progress of the disease. It's based on a transition in the family.
John, we have about 5 minutes left.
Okay, I'm getting it. The last area I just wanted to mention, which is a very big area, is family health beliefs. And one of the main challenges for families dealing with chronic illness is how to create a meaning for their illness that promotes a sense of competency and mastery. And there's some key family beliefs that I think are important to observe or inquire about. Often people, particularly younger couples or families, do not know what the average experience is because other families are not dealing with the same disease. I want to highlight just one here, which would be the cause of the illness. I think it's very, very, very important to ask each person in a family, do you have any ideas about what caused this illness? We all come up with ideas about what causes a cold. Now, if we're talking about cancer, beliefs that blame yourself or blame another person. If I say your nagging gave me my heart attack, I'm holding you accountable. It's a life-threatening illness, and our adaptation as a family or as a couple is not going to go well. That's a reason for referral. It's important to ask children. An example I had of that was once a 7-year-old boy was diagnosed with a bone cancer in his lower leg that required an amputation below the knee. When asked his 6-year-old brother, if he had any ideas about why his brother got cancer, this disease, he believed he caused it because 6 months earlier they were playing soccer, they were on opposite teams, and they were kicking the heck out of each other, and this sibling thought that his aggression, which one could think was normal sibling behavior, came out through his leg, went into his brother's leg when they were playing, and that's how his brother got cancer. If that did not get revealed, that child will eventually become very seriously symptomatic. So do not be afraid to ask children of any age. If they shrug their shoulders, then they don't have a theory. Cover this. The last thing I just want to say is mindfulness to ethnic and cultural beliefs. Often they become very apparent around a chronic illness. There's couples that come from very different cultures and ethnicities, and they enjoy their differences. But around a major chronic disease, there can be very different ideas about control, sick role, what kind and degree of communication, who should be in the caretaking system. Should outsiders outside the family be included, or is it an in-family affair? Also, normative rituals. Again, these are just some of the things, because often these become what was normative differences between people in a relationship can become like a Grand Canyon of very wide difference. So I don't know if there's any time for questions.
Sure. If you have a question for Dr. Rowland or any of our speakers, it looks like at this point we haven't had anyone submit a question, but please feel free to do so in the written question box in the control panel. And at this point, Dr. Rowland, should I pass to Dr. Davey?
Sure.
Okay.
Okay. So Dr. Rowland's model really is applicable for a lot of types of illnesses, and the one I'm going to talk about as an example are couples coping with cancer survivorship. I've been working a great deal with cancer patients and survivors at 2 cancer centers in Philadelphia with oncologists, and a lot of them focus on treating the cancer, but often when they make the transition from being a survivor, from being a patient to a survivor, they often feel lost. Next, and make this transition to being survivors. And so this is really salient because the Institute of Medicine recently wrote this report from cancer patient to survivor, lost in translation, and they really are asking providers to focus on helping them make this transition, not just for the patient who is now a survivor, but also for family members. I use adult attachment theory quite a bit, which fits nicely with Dr. Rowland's family systems and illness model. Those of you, I'm sure, know this theory that don't. It's really talking about, in the beginning, John Bowlby talked a lot about parents and primary caregivers' attachment to their infants and children. But it's also very important in adult relationships. They find that couples who have secure attachment, they tend to have better communication, better connection to each other, and better outcomes. And so our goal in my group, my research team, is to really work on couples who are survivors and improving their secure attachment to each other as they make this transition. A huge population is coming through who are going to be survivors. Thankfully, there's so many new developments and treatments that a lot of patients who would not have lived beyond 5 years are now living many, many years. And they estimate that in about 10 years, we're going to have millions of survivors, both males and females. And so this is a population for any of you who are working in cancer centers that are really going to need our attention. Prostate, colorectal are the 2 most common among male survivors, which I'll talk a little bit about. And then breast, uterine, and colon rectum are the most common among female survivors. So there's a lot of physical sort of repercussions of having had cancer. Once the treatment ends, many patients talk about coping with these different types of physical sort of symptoms. Some have fatigue and chronic pain after the treatment is ended. Some have what they call chemo brain or short-term memory issues where they have problems concentrating that can go away or sometimes lingers after treatment is completed. Others will have sensitivity to the touch, or they're so numb they don't feel the touch. And if you think about couples and relationships, that can really impact their intimacy, which I'll talk about in a few slides. Others may have lymphedema or swelling. And then many talk about changes in their weight or eating habits. They may have dry mouth or a loss of sense of taste. And last but not least, which is very common in prostate cancer survivors, some have very significant bladder or bowel control problems. So these are things, if you think about a couple, that can really impact their lives, but also how they relate to each other in terms of intimacy. The one thing that survivors report often is that they're really worried about how they're going to relate to their partners or spouses after the treatment is over. We've run groups with cancer patients in active patient care, and they're often fighting. They're in that warrior stance of, we're going to fight the cancer. But then once the treatment team ends, you know, a lot of things that come up is, okay, can I touch you? Are you comfortable with us re-engaging as a couple? These things aren't really always talked about, either with the providers or with each other. And so survivors talk about really, some of them with their body image. If you've had a mastectomy or you've had tumors removed, often they feel uncomfortable with their bodies. There may be some pain during intercourse with some types of cancer. Low sex drive is often reported. And for those women in particular who've had hormone treatment for breast cancer, they often go into early menopause. That also impacts intimacy. And then, of course, for prostate cancer survivors, many of them report having some erectile dysfunction issues. So given all these things, you would think that, and I would think that providers will prepare patients and their partners once treatment's about to end, what's next? And unfortunately, I'm not blaming providers, but they're often not trained or prepared to help patients and their partners talk about what are you going to do next? Now that the treatment team is leaving you, the mothership is leaving, how are you now going to reconnect and talk about all these things that might impact your relationship? And so a lot of providers I've talked to, they know it's important, but they often don't have time because they're really focused on treating the cancer. And then a lot of partners really aren't sure how to broach the topic because often they've been in the supportive role of really helping their partners go through this really tough treatment regimen. And so while the partner should be a primary source of support, unfortunately, inadvertently, they may become a source of stress if the patient or the survivor doesn't feel they can turn to that person and the partner doesn't feel like they know how to talk about things. And so here's where we can come in, those of us who are focused on family systems, developing more couple-based treatments to really help in this population of survivors and their partners, especially for low-income minority patients. The research that has been done so far, as most of the research has been
Maureen, it sounds like your sound has cut out just briefly. Would you mind repeating the information on this last slide?
Sorry about that. So basically, can you hear me better now?
Yes, perfect.
Okay, it could be the hotel. Apologize, guys. I'm at Bethany Beach. So for those of us in family systems work, this is a great opportunity to develop couples-based treatments. But we really need to think about how to make them more culturally relevant, as John mentioned, for couples who are not just white, middle class, or married, but who are a minority, who may just be partnered. And so most of the interventions so far are really targeting people who are in the active stage of cancer patients. They're having chemo and radiation, and most do not target both partners. So the things that have been done so far, either people have said, let's talk to the healthy partners and we'll train them to be a coach or to help the person who's a survivor or patient. The part that we're doing is we actually treat the couple as a unit, and you want them to learn things together and to turn to each other and to develop a more secure relationship so they can be a support for each other. And we decided to adapt an intervention by Susan Johnson, who developed emotionally focused couples therapy, one of these evidence-based couples interventions that really target attachment emotion called Hold Me Tight. Before I talk about Hold Me Tight, though, when I first started partnering with providers in oncology centers, a lot of them didn't know if they had anybody who was a couple. They didn't always ask, are you partnered, are you married? And so basically, what we wanted to first do is find out, survey the patients, are you a couple, and would you be interested in coming to a couple support group, which we did. So we did a patient needs assessment, and if anyone's interested, you're welcome to email me for that. Sloan Kettering actually graciously shared that with us. We surveyed about 150 patients at the two cancer centers in Philly, and 70% were African American. The average age was 50. A little more than half was female, and 65% were actually in a relationship, which meant they were married, engaged, or partnered. And surprisingly to us, 60% of these folks who were partnered said they really were worried about their partners. They really were affected by the cancer. They were concerned about communication and coping. They were worried about how they were providing support to each other, and they really wanted, half actually wanted to attend a couple support group with their partners, which we were happy to see. And so I know I'm running out of time, but here's a few of the questions we asked. And basically we wanted to find out how they felt about these things. Okay, so here is a copy of the book. It is on Amazon, Hold Me Tight. It can either be a for 10 weeks because the cancer patients felt like 8 was just too much, and so we reduced them to 5 because it was more feasible, and the providers felt like that would be doable given all the symptoms. Okay, I'm getting a message. Okay. My audio is reconnected? Polly?
Yes. It's kind of going in and out just a little bit.
Do you think
it's okay? Or it was okay? I think we're losing you right now.
Hold me tight, because we felt these negative things could be targeted best, and we wanted to really target the relationship and reduce feelings of depression and anxiety. The big thing that I really like about this group is we have one session, session 4, that's dedicated to talking openly about any sexual issues. A lot of them have a hard time talking about how the cancer's impacted their sexuality. And so we have this nice session where we actually open up with the couples. And what's nice about this group is they basically have a group of couples and a couple support group, but part of the time they meet individually as couples to talk privately, and then we bring them back together as a larger group to share what they're comfortable sharing. And so in this one session, we ask them, when do you feel most unsure or uncomfortable during your current sexual relationship? How do you deal with these feelings? What do you say? And how do you talk about these things without having any feelings of rejection or hurt? And the goal is to say how you're feeling without making the other partner feel less than or not desired. One example we had in our last group was a woman had had a mastectomy, and her husband was staying away from her because he was really afraid she was too sensitive to touch and was trying to be concerned for her. She didn't talk about it and felt like he was basically repulsed by her body. And what was really nice was that for the first time in our group, they actually talked about that they actually did want to connect, and they were able to repair that. So there's lots that can be said in a safe way that helps people reconnect in the groups. We also like support groups because compared to traditional couples therapy, for those of us who are family therapists or therapists in this line, it's too much. Up to 20 sessions is just too much for a survivor. And so the 5 sessions is just much more feasible and can reduce distress. And so we really do train our group leaders to very quickly get to the issues, but also make referrals after they're completed.
Maureen,
we
have about 5 minutes left, 4 or 5.
Okay, are there questions that people have posted?
No, not at this time.
Okay, so let me quickly go through, and then I will pass to Lauren. Here are the 5 sessions. I can't go through each of them in depth. We are actually going to be at the conference if anybody wants to come. The first session is really about having members join with each other and getting comfortable with the group and overviewing attachment and helping them more connect with each other in a secure way and open way. The second session is where they talk about all these underlying feelings that they maybe have not felt comfortable talking to their partners about, unmet attachment needs, and what they need from their partners. The third session is where we teach them to be more accessible, responsive, and engaged, which is secure attachment. And that 4th session I just mentioned is about helping them bond through sex and touch. And the last session is about helping them care for each other. Okay, I'm pretty much at the end. Here are 2 articles that folks can look up. For me, I love the Psycho-Oncology Journal. They have lots of really good psychosocial support interventions for folks working in cancer centers and Reagan's meta-analysis. And I will leave a few minutes if anyone has questions.
If anyone has questions for Dr. Davey, feel free to type them in, and we'll maybe circle back around with her after Dr. DeCabral-Ryan is done with her presentation. And at this point, Lauren, I'm going to pass the screen to you.
Okay. Do we have success with my screen, Polly?
Yes.
Very good. So I want to start by providing some context, identifying what we see as both normal aging processes and the unique challenges that arise for aging families. Aging is, of course, the interaction of biological, social, and psychological processes that can have an effect on development. And while decline occurs in some processes, growth, of course, can occur in others, allowing one to compensate and function adequately in his or her everyday life. What we generally find is that as people age, they often have greater confidence and the ability to integrate information in a way that allows for enhanced problem solving and coping with complex situations, even if they're new. And what we once referred to as normal aging is now often recognized as more of a disease process. For example, in the absence of disease, it is important to acknowledge that we do not expect every older adult to suffer from deterioration in cognition. Though some might have age-related change, such as slow processing speed, It's not, as we age, we also develop compensatory strategies that support continued learning and overall functioning. And similarly, personality remains stable over time, and if it doesn't, that should cue us to an underlying process that's impacting wellness. John mentioned that illness is something that all family members must face, and as we talk about aging, this remains the same. But here what I'll invite you to do is to think about the application of his model beyond illness and more broadly to consider late life transitions, which are often tied to illness. Transitions represent a passage between two relatively stable periods of time, precipitated by a significant event most often. The response to those events varies from one person or family to the next, and these transitions often take time to react to and manage. Late life is, of course, marked by multiple transitions that can co-occur and often do. And with each transition, there's concern for increased vulnerability to risk, such as physical or emotional decline. And if you think back to the model that John showed us, those can be acute transitions or things that are more chronic in nature. We oftentimes see that acute events are mirrored onto chronic illness in addition to the things that have already been challenging or burden to a family. And these are not only about oneself, but often about loved ones. So friends or family taking on new responsibilities and roles in caregivers, either near or far, patients and families adjusting to retirement and reduced income, or working a new job to counterbalance declining income. And with each scenario comes a change of sense of role identity and definition of meaningful activity, and establishing an identification with one's age group. The latter of these can be one of the more challenging aspects for many. As captured in the photo here, older adults often state that when they look in the mirror, they see their younger selves attached to the old identity that they may have had professionally or personally. If it is difficult to affiliate with one's age group when a person does not yet feel he or she is truly a member of the aging demographic, it also makes it challenging to explicitly and openly navigate the stressors of aging. And the photo here is done as part of a larger series by Tom Hussey reflecting that very experience. Patients and families, of course, also encounter the stress of establishing a home environment that's safe, which may mean making modifications to the existing home or establishing care elsewhere, and therefore relocating. Many of these things represent loss, functional loss, anticipatory loss, and changes in interpersonal intimacy, which, as Dr. Davey mentioned, has particular implications for couples. Though transitions provide opportunity for growth, Forrest Skogan reflects in his writing that he once heard a colleague say, "You've got to be tough to be old." And there's truth in this remark. To navigate these scenarios, especially when there is more than one at any one point in time, requires grit, strong social supports, adequate resources, and the ability to explore and interpret information that supports continued growth. When attempting to manage transitions in a healthy fashion, it's important to note that those that we label healthy are those marked by flexibility, capacity for problem solving, the ability to modify expectations and restructure routines. And in this process, we see that those who successfully navigate change are those individuals and families who demonstrate continued learning, acquiring further knowledge and skill that supports their management of a difficult situation. Transitions encompass both loss and gain. So a patient who was recently referred to me for adjustment to chronic illness has reflected on the fact that the illness itself feels impossible at times, but there have been benefits to that process. And what he's identified is that now, being forced into retirement by the illness, he's focusing on activities that he not had previously had time to enjoy. He's traveling with increased frequency despite physical impairment and making modifications to how he does this. And he's working with his family and wife to identify what the illness process means to them. And so in our conversations, we're preparing them for their role as caregivers. Who will do what? Who has the means to do what? And how does this align with the family system values and individual values that each bring? Just want to briefly reflect here on the implications and prevalence of disease processes that we see in our aging population. Approximately 6,000 Americans turn the age of 65 every day, and that number, of course, increases each day. Of our 77 million baby boomers born between 1946 and 1964, the oldest turned 65 in 2011 and can expect to live to about 83 years or more. What this means is that we have a multitude of people facing these transitions and in ways that we never imagined, and we have a shortage of clinicians specifically trained to work with an aging population. What you see on the slide here are weighted percentages of 12 months prevalence rates based on DSM-4 criteria of these diagnoses in a sample of over 2,500 older adults. And as you can see, the rates of depressive disorders declined with age in this study, and we can make hypotheses on why this is true, but there are also other researchers have researched generalized anxiety disorder and found this to be most prevalent of our aging population, though as you see here, panic disorder is also pretty high in that cohort of those 75 to 84. And what are people worried about? Well, many will talk about worry of falls, risk of injury, the fear of death, though this is notably much lower than the other worries mentioned. And the work conducted by Byers and colleagues demonstrated that rates were higher amongst women in each age group as compared to men. The rates don't seem to vary much based on race or ethnicity. As John mentioned, family is both a key resource and must be a partner in care. There's no doubt that when we care for aging parents, or aging patients rather, we must not only acknowledge but care for the caregiver. In 2014, Suzanne Mintz wrote, "The unthinkable had finally happened. I had become a caregiver who needed care." Having been an advocate for caregivers for the majority of her career, what she acknowledged was that most caregivers are woefully uncared for, representing an unidentified, under-recognized patient population. When we talk about caregiving, there are distinct differences between spouses and children. Spouses have, of course, vowed to support each other through sickness and in health, and often take on greater responsibilities for the care recipient, but are what seem to be more psychologically prepared for caregiving because of the relative salience of the role as husband or wife, according to Davies. And spousal caregivers recognize that they are responsible for an increasing proportion of household activities, but don't recognize this to be burdensome. Subsequently, spousal caregivers are likely to experience fewer negative emotions toward the role change that they might experience when their loved one is still alive as compared to adult children. Adult children are, of course, largely members of the sandwich generation, taking on these roles when they have heightened other responsibilities to spouses, young children, and work life. Additionally, in a world of technology, we see that oftentimes our caregivers, particularly for adult children, are those living cross-country and making decisions in secondary roles regarding financial management of things when they can't be face-to-face with their loved one. And so just as the patient is impacted, so too is the family, especially those who are in active caregiving positions. There's been a range of research about caregivers and the impact that caregiving has on those individuals and family members in such roles. And as you can see on the present slide, there are a range of biomedical, psychological, and social changes that can result from caregiving. There's evidence that these effects are different based on the demographics discussed on the former slide. What I want to pay a specific attention to is one of the items on this slide regarding sleep, which is to say that this is particularly true when the patient is suffering or acting out behaviorally in the night. It is much harder to get a good night's sleep when one is keeping an eye on a loved one through the night because of fear for one's well-being. As an example of this, I have a patient whose husband has been diagnosed with cancer, and she will describe staying awake almost all throughout the night because what she finds her spouse does is he smokes in bed, falling asleep and sometimes falling out of the bed with cigarette in hand. So you can imagine the implications of this on her own well-being. That being said, there is also research that supports caregiving having its benefits. Many identify this role as one that gives additional meaning, opportunity for closeness with a loved one, and/or a chance to repair past hurts. In this context, what we see is application of John's resilience-based model, shifting family focus to what strengths and resources they have to face, understand, and manage the illness process. Patterns of perceiving and behaving are transmitted intergenerationally, as John mentioned, and so we can see that there are many strengths that we can draw upon and think about to manage situations, and I'm happy to talk about this more, but I'll sort of pass over it given John's discussion of multi-generational issues and some of the strengths that, or past unresolved issues that arise that need to be addressed. So what's our role? Well, older adults represent 36% of hospital stays, 49% of all hospital care, and 50% of physician hours. And so older adults represent a fair amount of outpatient care as well. While there's longstanding recognition that good geriatric care requires attention to psychosocial aspects of the experience, a study by Haley and colleagues found that many were unaware of the supports that psychologists could offer to patients, and that psychologists were not necessarily adequately informed about the medical aspects of aging and the intersection between the physiological disease process and subsequent mood disorders. We've certainly come a long way since that 1993 study with programs in geropsychology and focus on primary care integration, but barriers remain true. How will these parties be reimbursed? How do we demonstrate that this is different than case management? And how do we address long-term needs? Integration, of course, can occur across multiple different settings. So how does this look in long-term care versus a skilled nursing facility versus outpatient treatment? Ultimately, across any of those settings, we can have dialogue that is focused on the content that you see here. And ask the questions that John mentioned. What has the family been told? What do they believe? And how does this inform how they'll proceed? Interventions can focus on enhancing communication on the topics that you see listed, and doing so can often occur proactively when family members are guided in this direction, making them more aware of how to engage in medicine, how to be advocates for themselves or for their family members, and determining caregiver roles in advance of meeting them. This can be particularly helpful around driving. You'll see that some states actually have documentation for this very purpose to help families navigate difficult conversations preemptively before they actually become difficult, making contracts amongst family members about how to manage these situations as they arise. This allows for an opportunity for psychoeducation, anticipatory guidance, and even management of anticipatory grief. And these topics can be addressed through problem-solving therapies, assertive communication skills development, application of interpersonal therapy, CBT, and narrative models. Additionally, behavioral health can play an integral role in palliative care conversations. This can often be not only for the benefit of the patient and the family, but for the medical team working with the family. If you think also about John's application of the use of timeline, this is not a conversation that needs to happen right before death becomes imminent, but one that can happen over time preemptively again. This has been particularly true for me recently. I'm working with a family where the grandmother is the primary guardian to her grandchildren and facing multiple comorbid chronic illnesses that we anticipate will result in the end of her life in the next year or so. And her worry has really been about her grandchildren. And so our focus has been on what are her needs. How do we take care of her in a way that informs her family of what she's looking for and informs her medical team. And so in establishing care for her grandchildren, she is feeling much more prepared to make decisions that are more in accordance with her values about what treatments she chooses to pursue at this time and those that she doesn't feel are necessary. Making more informed choices and also helping the team honor what her wishes are. Lastly, behavioral health can play a critical role in any of the clinical settings where older adults may be encountering transitions with their families. Notably, physicians will frequently report feeling inadequately prepared by their own training to facilitate family meetings, and psychologists and other behavioral clinicians, particularly those with systems training, are well prepared to facilitate those types of conversations with emphasis on complex psychosocial matters. In this process, you can also help to identify community resources and supports that might exist that can ease transitions both for the individual and the family member. This process can also occur through consultation, recognizing that within primary care this is already a fairly regular occurrence. You can also imagine its application to an aging population. So frequently I'm contacted by psychologists with inquiries about what's within their purview of consultation and care, many stating that they don't feel sophisticated in responding to death and dying or providing neurocognitive screens. I encourage people to seek further supervision as they need it, while also acknowledging that in primary care you may be the only person available to do this important type of work. If you're not comfortable with distinct cognitive processes, you can at least conduct a brief screen that helps you understand whether or not there is cognitive decline that might warrant further higher level evaluation to differentiate between Alzheimer's disease, Lewy body disease, and so on. In addition to those types of consultations, you can offer support in ethical decision making. The ethics of aging are, of course, complicated, as are many other things, but when we come to end-of-life issues, who should be participants in patient care, spouses, ex-spouses, other family members, we can often find that the waters are relatively muddy. Recently, we conducted also a specific intervention for older adults leaving the hospital, looking at their psychosocial needs and trying to acknowledge these in a way that informed us better that we could better manage their medical illness by acknowledging the cognitive decline that they might be facing or the psychosocial stressors. And as a byproduct of this, what has ended up occurring is my role has become more focused on consultation to the larger hospital system in this application of just simply the PHQ-2 to have folks understand that the patients leaving the hospital are often facing great significant psychosocial distress that needs to be more adequately addressed to ensure a safe discharge. And as you can see in that process then, there is significant education that happens to interdisciplinary teams and trainees of all sorts that are trying to understand how to work with this population. And with that, I'll again open it up to questions for myself or back to John or Maureen.
Sure. And this is Polly. Lauren or any of our panelists today, we do have one question from Monica Frazier. And the question is, as we recognize the need to work across medical settings, especially when patients are diagnosed with multiple conditions, what is your advice for engaging with other settings who may not understand or value the role of mental health work? And I think this is directed at any of our panelists today.
I mean, I guess for me, working in cancer centers, it was starting slow and building relationships and showing them what I can offer them and their patients. And so I now work in a palliative care clinic as well as in a cancer clinic, and realizing a lot of the providers are burnt out and need our support. And so I think if you can start small and build relationships and show them what you can offer, that then things can go from there. And so now they want to work with me because I've shown them that I can actually offer them and their patients something that's going to be helpful and reduce distress for them.
This is John. I think one of the things is having families advocate if they have multiple providers or in multiple settings. Part of what I do is help educate the families to be more assertive with these other systems. So in some ways they promote the collaborative process. And doing that early is important. I think it's more difficult once, sort of when you enter a situation where there have been multiple providers and they've operated in their own silos around a family in a chronic illness for a while, you're sort of working backwards. So early and enlisting the family as part of the resource.
I agree with both Maureen and John, and I think the relationship building becomes really critical. I recently had a GI specialist reach out to me because she had actually seen my documentation and a surgery note, and she requested to speak with me just to get a better feel for the kinds of service that I might provide. And what she articulated was that she feels herself really alone and very burnt out in trying to provide care to those with chronic illness, that she doesn't have the skill set to do that. And so working together to acknowledge what strengths we each bring to the table and then determining how I can be of help and moving forward in that way. I think without the relationships, you can't do that.
Excellent. We have one additional question in our last minute or two, and this is from James Wagley. How do you see universities preparing psychologists, LPCs, and social workers for providing integrated behavioral health services?
Long question. I think one of the things I saw is the interdisciplinary training. I think that's one of the things that, to the degree to which you can have team discussions where these various providers, in this case you're talking about different behavioral health providers, but I think integrating that with providers who are on the more biomedical side, so anywhere in training where you can have presentations, case discussions, where the value of each person's discipline is validated is important. There's clearly overlap here because in terms of what we're talking about, today. The three of us come from different disciplines, but we're talking about skill set and knowledge that should be a part of any behavioral health training.
I agree with John. So some of the courses we offer, I'm in a nursing college, and we have interdisciplinary classes and also placements in different clinical settings where they work together as a team and they learn from each other. So any chance you can build that in the curriculum or in the training, that's a great way to prepare people to deal with working together and appreciating each other's points of view in a team.
Very good. Thank you, Dr. Davey. And I'd like to take a moment and thank each of our speakers today and thank all of our participants for joining our monthly webinar. Just as a reminder, the CFHA annual conference will be held this October in Portland, Oregon. You can see our website for more information, but we do have a very strong families and health track this year, so there will be numerous breakout sessions focused on family and across the continuum of care, from primary care to specialty care and all kinds of things in between. So we'd encourage you to register for the conference, and we'd love to see you there. Thanks again for joining us. This webinar has been recorded and will be on the CFHA website in approximately a week. Thanks so much to everyone.